Today we will be reviewing landmark papers in peptic ulcer disease management from the East Landmark Papers in Trauma and Acute Care Surgery online resource. This analysis of the nationwide inpatient sample demonstrated a significant reduction in peptic ulcer disease hospitalization between 1993 and 2006. The largest reduction was seen with regards to duodenal ulcers. Inpatient mortality was also shown to decrease to 2.7%. Hemorrhage was noted to be the most common complication, but perforation had the highest mortality. Enders and colleagues performed this randomized control trial in 2000 comparing patients with perforated duodenal ulcers randomized to quadruple therapy compared to 4 weeks of omeprazole. At 1 year, there was a significant reduction in ulcer recurrence in patients that underwent quadruple therapy. This new meta-analysis analyzed over 800 trials in over 142,000 patients. Trials were evaluated for prevention, healing, and treatment of acute upper GI bleeding. PPIs were shown to have the largest reduction in upper GI bleeding and were the most effective in gastric healing trials. This well-cited randomized trial evaluated patients that had recurrent bleeding after undergoing successful endoscopic treatment for a bleeding peptic ulcer. The vast majority were treated successfully with repeat endoscopy and had fewer complications than those patients undergoing open surgical techniques. Large ulcers and hypotension, however, were noted to be predictors of endoscopic failure and may best be treated by surgical intervention. This Cochrane review analyzed 3 randomized trials to compare laparoscopic compared to open surgery for perforated peptic ulcer disease. While no statistical significant differences were found for either intra-abdominal or extra-abdominal complications, the authors did comment that the sample size was likely insufficient. There was a trend towards a decrease in surgical site infection, ileus, and mortality with laparoscopic surgery. A more recent meta-analysis evaluated 29 trials comparing laparoscopic to open repair of a perforated peptic ulcer. Laparoscopic repair was associated with a decrease in postoperative complication, earlier resumption of oral intake, shorter hospital stay, and a decrease in mortality. This well-cited study evaluated 83 patients with a diagnosis of perforated peptic ulcer disease. They were randomized either to immediate operation or a 12-hour non-operative trial. Those in the non-operative group received nasogastric suction, IV broad-spectrum antibiotics, and IV ranitidine. Only 28% of the patients in the non-operative group ultimately required laparotomy. The authors did not feel any of these patients suffered additional morbidity by the delayed operation. They did note, however, that hospital stays were significantly longer in the non-operative group, but the overall morbidity and mortality rates were very similar. Patients older than 70, however, were less likely to respond to the non-operative management compared to their younger cohort. This study by Schroeder and colleagues utilized the ACS NISQIP database from 2005 to 2011 to evaluate the treatment of peptic ulcer disease. They found that for the treatment of perforation, a simple repair was equivalent to vagotomy and drainage but had a lower morbidity and a shorter hospital length of stay. However, for bleeding ulcers, they found that vagotomy and drainage was associated with a decrease in mortality. This well-cited study sought to evaluate the management of the difficult duodenal stump after a penetrating duodenal ulcer. Classic duodenal stump closure, which was a distal gastric resection with direct closure of the stump, and Roux-en-Y gastrojejunostomy was compared to duodenojejunostomy. The authors reported a significant decrease in mortality and leak rate with duodenojejunostomy. The type of procedure performed was at the operating surgeon's discretion, and the authors do note the potential for selection bias. These final 2 papers evaluate the historical surgical management of peptic ulcer disease. This paper on the left is from the British Medical Journal in 1929 and describes a pedicle limental plug without primary closure of a perforation. The paper on the right from 1982 in the Annals of Surgery evaluates patients prior to the use of PPI therapy and H. pylori eradication. It may be applicable to non-compliant patients or those who will not be able to receive contemporary postoperative care.